Thanks for coming, Sue.
That's okay.
Would you be able to kick off and just let us know a little bit about your experience and what you've done in primary healthcare?
Righto. So how I got to primary healthcare, I trained at St Vincent's Hospital in Melbourne, and I went into cardiothoracics after my training period. And I wasn't in that job a whole long time before I discovered that people weren't worrying about how anyone ended up in acute care. They were treating everything as it hit the door. So after a while of that, I thought that this is fairly pointless because it's the old ambulance at the bottom of the cliff. You just wait for them to fall off and pick them up and bring them in. So from there, I ended up in general practice, or sort of a few stops along the way, but general practice, because the whole idea being to stop them ending up in acute care in the first place. So, yeah. So 20 years general practice. I know primary healthcare is a much bigger thing than general practice. That's often initial contact, though. Yeah. So I'm sure you guys all know lots and lots of work and know a lot about it. It was just more specifics if you had things that didn't come to you through your reading. Yeah.
Does anyone want to kick off with a question?
What is primary care?
Primary care really is initial point of contact. So someone goes to a health professional with a perceived problem. Often that is general practice, but it can be other points of contact as well. You know, people can go to physiotherapists, they can go to dietitians, ranges of people with problems that they've identified with their health. Yeah. So it does often end up back in general practice. So thank you, Cherise.
No worries.
The general practice, if you like, is a gatekeeper. So people come in, problems are identified if they exist, and then they're referred, hopefully appropriately, into a much bigger primary care network quite often. Yeah. Thank you very much.
It's all right.
It was a long run from the cup. So, and over time, I think the thing that became so important is really managing people who do have healthcare issues. So to have them managed is going to prevent acute flare-ups, if you like. And it's only when you're young and your problems aren't that big that you ever recover fully. Okay, so let's take, because my specialty area was respiratory illness. So if you take respiratory illness, for example, if someone has, say, a chronic obstructive pulmonary disease, they get an acute infection, or they're not managed well, they become very unwell, they end up in hospital. They're treated to recover, and they sort of recover to there, but you never get them right back. So as you can understand, over time, without really good primary management and the patient knowing what they're doing, why they're doing it, and being very proactive about it and supported with it, each acute episode, you're going to slip, you'll only get them up a bit more. And on it goes. Yeah.
Sorry, what kinds of primary healthcare services are there?
It's very different for every area. So you
Say
really...
for elderly people?
For elderly people, general practice again, they'll be managed through general practice. They will see specialists quite often, and the specialists will prescribe treatments and therapies, but the management's all coming from the general practice. Within the general practice, if they have a chronic illness, which a lot of them do, which is something perceived to last for more than 6 months, they will be then put hopefully onto management plans, and they'll have, if they're complex needs, team care arrangements. So that's referral out to podiatrists, physios, dietitians, whatever's seen as appropriate. And podiatry kind of sounds a bit, oh well, that's nice, but podiatry is essential for so many illnesses, because if you cannot stay mobile, you cannot maintain your health. You'll just decondition and decondition, and it's a slippery slope. So yeah, but you do have to find within your own area, if you're working in primary care or you're working in general practice, you do have to find all your networks in your area, because they're very different. Bigger places have more than perhaps smaller places, and some smaller places have quite specialist services. If we take Colac, for example, they've got a very strong disability industry, so there's scope within that. Mental health, not so good, really. You're sort of coming Geelong way to get public mental health care all the time. Yeah. So yes, you have to find out what's in your area.
So that would be some barriers to care, would be if someone had a mental health issue and lived in Colac, the bulk of the services for mental health are in Geelong. And so given that perhaps the proportion of people with mental health issues are unable to work, so therefore they probably don't have, a stable income, perhaps. And so then there's that financial barrier as well, being remote with a mental illness, and services being very...
It's very important, because it's no good drawing up a plan if the person is not able to enact it. So it's very important to know what's a person's
realistic.
circumstances are. But once again, if you really drill down into what services you have available, most city councils have what we call a Red Cross card. So you can book that. That can be booked, and they will drive. We have patients coming down the road every day from Colac with a driver being bought for all sorts of healthcare. So, yeah. And you'll see, look on your city council websites, look on your health service websites, and you'll get quite a list. Yeah.
Have you heard of the health illness continuum?
There's lots of terms out there, healthy, and I think that's almost what I was talking about. Did you interpret it that way, or what was your interpretation of the
I haven't quite
health
worked what my interpretation is quite yet,
But right.
but it's question 2 on our assessment task.
Right.
So I thought I'd just throw it out there.
Yeah, because it's just a
I
term.
know there is a graph somewhere in there, isn't there? It's
Mhm.
probably
Yeah.
in the resources that you've given us, but I just wondered if it was a term that was used commonly. I work at a medical centre and I really haven't heard it,
Yeah.
so I just wondered if you had an interpretation of what you thought it might be.
Well, not really. I mean, if I think of it, as I said before, with, they're well and then they're not well, and on it goes. So at what point do you intersect to make sure they're not going to go from well to down here before anything's done?
I guess it's a little bit what you were just explaining. So they become acutely unwell, and then they only ever get back to that level.
Yeah.
So if you look at it on a continuum that way, right?
Yeah.
I mean, you were describing it physically that way, but you could almost describe it that way, so that there's wellness, that that's their level of wellness. They become really unwell, but then they only get back to here. So you're gradually creeping to a different end of the continuum every time you become unwell.
So your normal changes
And it
for
is
that
measurement.
for the person that's being sick, so they were here and then they're never going to get back to there.
They're never
so
gonna get
their normal's being reduced in some way.
Adjusted.
And it's management over time, because if you look at someone who hasn't had the benefit or hasn't want to engage with primary health care, and let's say they've had 6 acute episodes in 12 months and they've required hospitalisation, they've struggled to get well, but then if they do engage, you might look at it and say, well, this year you've only had 2, and the year after you've only had 2, and then you've had 1. So it's the continuum, is how I see it.
Mhm.
Whereas if you have 6 and you still don't engage, and then you have 8 and then you have 10, that's
Deterioration.
that's a decline.
Mm.
Hospitals have a flagging system, so if people turn up, I forget how many times now, it's so many times in 2 months or 3 months. If they present to emergency department, that's a red flag, and that initiates what they call the HARP team, and it's their job to facilitate those people to work with their general practitioners and with healthcare planners to try and get some education around management, because education is really key.
Sorry, so what's the HARP team?
Well, I'm trying to think what the initials stand for, but
It's
they
an
work within
it's an acronym.
Yeah, it is an
I'll
acronym.
Google it.
Yeah.
Thanks. We all know what it is, but
So
we just
there's-
can't tell you the
There's
acronym.
at Barwon Health, there's the HARP
HARP
team,
team,
and
all
so through
capitals.
our electronics, as patients come through Barwon Health, for example, they'll come through electronically, and there'll be some sort of visual flagging system that comes up in what's called BOSNet.
Yeah.
And then the HARP team will probably keep track of that, and then they just come and see the patient before they're discharged.
Yes,
It's the Hospital Admission Risk Program.
yes, thank you.
And Mostly
Generally
run by nurses, yeah.
Generally nurses.
Mm.
We've had a couple of pharmacists, but that's unusual. Generally nurses. And they attend the appointments with the patient. They get the patient to the appointment and they provide the support in the home. But the patient has to proactively engage. So if there's not seen to be any engagement, they're ignoring everything that's said. Well, they stop being qualified, if you like. And there's no limit to how many times people can have HARP assistance. It's a great service. You know, they bring them to specialist appointments, so they're sitting in on the appointment. They've got the benefit of the knowledge of what the gold standard management is for that client.
I guess with that support, it's good because it's easier just to call the ambulance and go there to the hospital for free than to get a taxi and pay money to go to your GP.
And
But having
sometimes,
the HARP team to
unless
help
someone's
you.
explained it to you, your care,
Yeah.
it mightn't even make any sense. No, because people are very, very busy in general practice. General practitioners are so ridiculously busy. It's just crazy. When I worked in hospitals, I'd think, well, what are they doing? You know, they can't even write up a drug chart. Where are they? And you wait and wait. But boy, when you see what they're doing, they really work flat out. So it's very hard for them to have the time to sit down and say, well, this is what you've got to take, why you've got to take it, how long you've got to take it. So people can be very confused. They think, oh, I took it for a few days and I'm all right, and sort of just let it all go into the past. You know, it's something they're associated with not being well. And it doesn't take very long before they're not well again because they didn't understand that that was required in an ongoing capacity.
So does everyone understand that in a GP practice that there's, so that Sue would be like the practice nurse in the practice?
Well, we had a
being-
big practice, so
Mhm.
yeah, I was nurse manager, we had a big team
Mhm.
and we were what you call a procedural clinic. I don't know, your clinic is
East
procedural.
Centre, yeah, we do procedures
Yes,
in
yeah.
there.
So you've got, we had 5 and a theatre and visiting specialists and health educators, so tertiary trained diabetes educator,
Diabetes
respiratory,
educator, yeah.
women's health nurse. So all working to optimise patients' health.
Because you were saying that the GP doesn't get time to explain
Not
all
to
those
educate.
nuances, so then
Yeah.
that job falls to,
Yeah, quite often.
yeah.
Younger general practitioners are much better, I find. And they also look for their teams. So they come into general practice, the young ones, and they'll say, where's my team? Who's doing the diabetes education? Who's doing the respiratory? You know, what sort of services are we with? They really do, whereas the older guys, not so much.
They manage their time better too, the younger doctors.
They do.
If you come in, you've got 10 problems, they go,
Yeah.
you need to come and see me again in a couple of days.
Yeah.
I can sort out this and this, but then you need to come back.
Yeah, and they, not all of them, but a lot of them are good documenters. Because if someone comes in and they've, let's say they've got arthritis, the doctor's talking about the arthritis, they might manage to sort of get that under control a bit, but if they haven't addressed what they call SNAP, smoking, nutrition, alcohol, and physical activity, well, you're pouring treatment into a bucket with a big hole in it. So I find the younger ones are also better at that, at doing that quick discussion about where they're at with other health issues.
And they're also more realistic about their patient loads
Yes,
as
yes.
well, whereas the older guys have got, they're a bit, their lines are a bit blurred as to what they can and can't do, and they give out their mobile phone numbers and things like that, whereas the younger guys are
Yeah.
more, this is the procedure that you need to follow, they're more structured.
Yes, I think it's sort of it's a period of change.
Yeah.
Yeah. My dream was that Medicare would actually pay for longer consults for patients.
Yeah.
You know, they wouldn't have that revolving quick turnover, but I didn't see
I
it
think a
anyway.
bit of that's based on bulk billing compared to private.
Yes.
Those
Yes.
and that, I've worked in both,
Yeah.
and there's a little bit more of an expectation when you're paying
Yes.
that you will get that amount of time and you will get more service,
Yes.
even though, you know, that's not stated as fact,
Yeah.
and that's not the case for all the
Yes.
doctors, but that's what we find.
And plus, do you have clinics? I know I went to visit a clinic and I asked them what they do to, you know, to support their patients with drug addiction and people who weren't able to pay bills and do things like that. And the practice manager looked at me horrified and said, "We don't have any of that.
No.
We're a white collar clinic." So it is very different.
What does white collar clinic mean? Only
Mean
the working
they-
men?
Yeah, professionals and jobs, and
Oh.
they didn't see much disadvantage at all. And indeed, the general practice looked like the Taj Mahal.
So blue collars like tradies,
Tradies.
whereas white collars like businessmen.
And there is a distinct difference between
Yes.
practices. I've worked in a bulk
Yeah.
billing clinic that was just a high turnover, and then I've worked in a private practice where they pay.
Yeah.
And the distinction between the
Yeah.
patient load and clientele is huge difference. We don't get many drug seekers in our clinic, whereas the other clinic had a lot of drug seekers, and that was difficult at times. And there's a big gap in the mental health area as well, just where people can go to get help.
Yes. Yeah, and the wait times. So if you're in crisis and you have to wait 2 months,
Yeah,
it's not that fantastic.
no.
Yeah. And the same as I was talking about before, let's, work towards doing something about it before they're really at the point where they're so acute. It's just going to be masses of treatment.
Mm.
But it's a funding issue.
Yeah.
Indeed. So what else challenged you when you had a list of dot points? I had a quick look on what's required for your assessment task.
Describe the philosophy underpinning primary health care.
Isn't that great, that word philosophy? Because nurses are doers, and I saw that there and I thought that's such an academic word. But I think taken out of academia, they mean your attitude. Correct me, Lara, if you see it a different way. But I think they're referring to people's attitude and their belief system around primary care. Okay, and that comes back to roost with the two different setups for clinics. If you've got a lot of very wealthy patients, there's a private clinic out at Brighton, and the drug reps tell me if you want to see absolute gold standard care, everything perfectly as it should be, go and have a look, because money is flooding through the door and their patients are all very high profile and they're terrified they'll get sued. So, their philosophy will be about providing to that clientele, whereas the clinic I worked in, our philosophy would be that we welcome everyone, we do the very best we can for everybody, even though it is under difficult circumstances. And that's about as good as you can do sometimes.
Who develops that philosophy? Because the GPs own the clinic, they're the owners
Yes,
of the clinic
yes.
as a board or collective, and you said you were the practice manager. So
No, I was nurse manager.
Nurse
So we're
manager.
a big enough practice to have departments, if you like.
Okay, yeah.
Yeah.
So, if you come into that, there's already a philosophy created. So, does it change over time as to?
I don't think there was a philosophy created, and it goes back to the older GPs again that, like to keep their father, who was a GP before them's leather medical bag in the car and cook the
I reckon
50 degrees. They just work.
I reckon GPs themselves seem to be the ones that govern that. So what I find is we've got some GPs that charge a lot,
Yeah.
some GPs that bulk bill, some GPs that are bulk billing and charging.
Yeah.
So it almost feels like we've got 13 doctors and they're each
Yes.
got a different philosophy
Yeah.
on how they run their client load.
But I can assure you, if you ended up in a management position in that meeting room at the back of the building, there's a fair bit of pushing and shoving going on with the ego saying, we're going to do it this way, and they say, well, no, I'm going to do it this way. But long before I left, the clinic had written up a mission statement, so they realised they needed to do that, and that coincided with getting a very well-trained practice manager. We had a change in practice managers, and she was very quick to bring all that up to speed.
Does everyone know what a mission statement is?
Yeah.
You don't want to have a go at defining it?
Admission statement.
A mission statement.
It's like what you plan to do.
Everyone's
It's
Yeah.
saying the
it's
same.
like
Everyone's aware of this.
it's what you're trying to achieve or what you're portraying.
So yeah, so basically your goal, that your collaborative goal that you want to achieve as an organisation. And a lot of big organisations will have a mission statement. Barwon Health has one. Most companies will have a mission statement.
And it's
So-
usually on their website, isn't it,
Yep.
Cherise? You can hop on and they like to put it right up the front so you can see how they're badging themselves, if you
Yeah.
like. It's part of their badging.
And a lot of, when you go for jobs, a lot of people will ask you, you know, do you know what our mission statement is, or do you know what our values are?
Oh,
So that's something you should always familiarise yourself with when you're going for a job. Okay?
We in ICU we drill down to actually having our own values. So we've got the Barwon Health values, but we actually have our own sub sort of mission statement of in how we want to deliver care in ICU. And a lot of departments are doing that within Barwon Health as well.
Mm.
Yeah.
It's
And
quite
again, it's like a
specialist.
philosophy of how we want to
Yeah.
care for and treat our patients.
Yeah.
Your end goal.
Mm.
Yes.
so the main two professionals that deal with the primary healthcare management are GPs and nurses.
Well, nurses who work in general practice, but not if you work in a hospital. So, yeah, general practice is by and large the main one that deals. But then if you have people going to Barwon Health for allied healthcare, that's a big primary care sector as well. So they might be going there for physiotherapy, to see dietitians. Yeah, and don't forget dentistry. Dentistry gets so forgotten. That is huge. If people aren't looking after their teeth, they're really at significant risk. Heart disease, associated problems, and it's too expensive in this country. So it often is something that if you don't look, you won't know, because people are very embarrassed and they'll try and hide that. And the other thing that's not very recognised is the fact that quite a number of people you'll see do not know how to read and write. And that will be hidden as well, because that's quite embarrassing, but a lot of people are coming out of school, a lot of men in their 20s and 30s, and they really can't read and write. And I used to, if I thought that might have been the case, ask them to write down some dot points of what I was talking about. And that would usually lead to them tossing it on the desk and saying, oh, I'm really embarrassed, but I don't know how to write. I can't read very well. So no good giving that person a great big handful of leaflets and handouts, because they're going to go into the bin on the way out the door. Yeah, so that's a big thing in primary health care, because you might be the only person that patient came to speak to.
That was one of my questions, was what are some of the barriers you've observed that people face getting access to primary health care? And so you're saying that
That's a big one.
a level.
Embarrassment.
Yeah.
Yeah. And also it can be if you've got someone who's older, who doesn't have good,
health literacy.
doesn't make good lifestyle choices. And they can be a bit embarrassed as well. And if they've encountered perhaps an older, very gruff general practitioner in the system who's sort of read them the riot act a little bit, that can disassociate them for a long time. So when they come back, they will be very wary and might even be a bit negative,
Have their backup,
defensive.
yeah.
Very much so. So don't worry about that too much. If you get that,
Yeah.
don't worry about it too much. Yeah. If it's just a little bit, worry about it if it's a lot. Yeah.
What's an example of where you've been able to make an early intervention with someone, with a patient that you've had?
Well, as a practice nurse, you're more often likely to have an impact way down the track, because they haven't ended up needing team care work until they've got significant problems quite often.
So would you
early
measure that
intervention.
with respiratory, like you were saying?
Respiratory.
Is
very-
if they're avoiding during the flu season a hospitalisation, that's a win. You know, how do you measure it? Yeah, how do you do it and how do you measure it?
Yeah, you measure it by seeing the patient very regularly. So if they're on a management plan, if you think it's necessary, and you work with the GP on this one every 6 months if it's required. So that can be tied in with them needing new scripts. So let's say it's a respiratory problem every 6 months. The absolute luxury of being able to sit down with someone, do their lung function test, go through what they're taking, get them to talk to you about why they're taking it, is it making a difference, and practice using the device, because no matter how good you are at using the device, within 6 months, 12 months, the technique's sort of slipping. So if the medication's not getting to where it needs to go, the patient's not getting the outcome. So some people only need every 12 months, and once again the luxury of measuring over time. So kids with asthma, if you're only seeing them every 12 months, you get to do their action plan for school. So they've got a current action plan, they've got all their scripts, they've had a practice with their inhalers. So those kids, look, to be honest, when I think back now, the reason why I ended up doing that as an add-on was because one of the older GPs came to me and said, that's it, I'm finished. I am so sick of getting up at 2 o'clock in the morning to go to emergency department to see people that shouldn't be there. You know, they're not taking their puppers, their asthma's out of control. So go and do a course and teach them how to do it. I won't let you guess who it is, but yeah. So I thought about that for 2 months because I didn't really have a great interest in respiratory care, and then I thought, what am I doing? That's a doctor asking a nurse to make a difference. So I found a course at the Alfred and off I went, and then I just continued that on. So lots of study, and one thing led to another. He didn't have to go to emergency department anymore. It's very rare, or it was, for anybody to end up in emergency department. If they were identified and referred in, they knew what they were doing. So then the spirometry came because he said, well, I can't measure, perhaps we can knock the dose back a bit. So spirometry, we could measure. Yes, a lot of people got to reduce dose. And then the smoking, so I trained at a smoking cessation facility because he said, well, they're chronic obstructive pulmonary disease, we're not getting anywhere because they're still smoking. So that became a respiratory module, if you like, and they were measured over time, and it was great to see outcomes. I'll just say one more thing so I don't forget. The only sad thing about it was people who actually quit smoking and couldn't believe it, and they felt so proud of themselves. And when they went to see their cardiologist, they were all excited, or the respiratory physician, all excited, and couldn't wait for him to ask them, have you quit smoking? Because he'd been picking on them, and if he didn't ask. So it's so important to ask, and that was heartbreaking, and they'd ring up and say, you didn't even ask me. So it is important to ask. And they will also say to you, I didn't think it was that important because nobody asked me. So always ask. Yeah. Sorry, I interrupted you because I didn't want to forget that.
Sorry, what's the most challenging thing when it comes to primary healthcare?
Challenging.
Is it like always repeating yourself, or?
No, I didn't mind doing that really. I didn't mind because you are always repeating yourself, but you also have to remember who's sitting in front of you. Okay, so the person sitting in front of you, you have to be able to identify how much information they would like or want, or how much they're going to take on board, so that you don't scare them out of the place the first time in if you start sort of going on and on and on. So you do really have to tailor it. And then you get to another level where the person sitting in front of you is a trained veterinarian and knows about 50 animals, not just the one human, and you have to be quite careful and quite accurate in what you say to that person. And then you'll have lawyers and things like that, so you always have to be very careful in what you say to that person. So I didn't really find that it was the same.
Is it challenging, because if you're doing primary healthcare with a child, you were talking about action plans and asthma management plans for little children, because you're actually educating them, it's the child and the parent together. So are there any challenges? It was the same consideration, so their level of health literacy and where you're pitching it with the parent?
Always.
Yep.
And it has to be remembered always. And encouraging that person to ask what do I want to know, what do I need to know? And also to include other people, because I find quite a number of people who are very aged now and have all sorts of limitations are not in nursing homes necessarily. They try to keep them at home as long as they can. So they'll be assisted from the City Council with help in the home. So if that patient is struggling, it's really a good idea, if they're happy, to have the person that comes to them most come with them. Because that's the person that's going to knock on the door and find them collapsed on the floor. Or that's the person that's going to notice if they're deteriorating. So to have them involved, I found that invaluable. And the patients did too. Because, Mrs. So-and-so that came 3 times a week could remind them. Yeah. So challenging if people are unsupported, certainly.
And how do you follow up, support them? So for example, you're encouraging them to ask questions, and have a snapshot in time where they have 15 minutes to ask the doctor, and I don't know, however many, whatever length of time the nurses have scheduled for them to discuss education stuff. What about if they have more questions? Do they need to make an appointment to ask more questions? Is there like just a phone call that they can make? So what sort of...
They always ring.
Yeah.
They always ring.
And so
Or
then...
just come into the treatment room and, you know, the nurses would make space for them along the line, and when you can get to them, that sort of thing. No, it was always that option to follow up.
Yeah.
Yeah. Getting them to come back when they felt well was probably the biggest challenge. You know,
Yes,
feel
had well
terrific, taking
visits.
everything, I'm fine, I
Yeah.
don't need to come.
Yeah.
So that was a challenge, and that involved phone calls and
Yeah.
explaining why it was important, really. Yeah.
Anyone else got a question?
Sorry, excuse me again.
With I know that there's like the nurse on call where you can call the
Yes.
nurse.
Yeah.
Is that considered to be primary care as well? Or not?
Yes, that'd come under primary care umbrella. Yeah. Yeah, that's a great option to have. Doctors aren't as excited about it as nurses because it's very hard to get anything done when the phone's ringing all day and you're just trying to triage patients. And yeah, you get a lot of jobs in general practice. Because the girls, usually females, sometimes males, that are manning the nurse on call line, have got a very strict format of questions to go through. And as soon as they get way down from the top, it says go and see your doctor.
Yeah. In 2 days or 1 day?
Or 1 day, yeah, so they sort of boo-hoo it a bit and say, oh, they tell them to come and see the doctor anyway. But I don't think they've got any idea of how many are calling.
No.
It just feels that way. Yeah, feels that way. But yeah, that's a good service. And some, Bupa, I think, is a health insurance company, one of,
I think the
A
nurse
few
on call
that
works
ring?
through Bupa. I
sorry.
think they work through Bupa. The nurse
Oh,
on
you're
call.
thinking of that system. Well, there's a
Yeah.
government-funded nurse on call where you can ring for anything at all, 24 hours a day. But the one you're talking about through Bupa is they actually pay nurses to ring people up and follow up, and because they're trying to save on their insurance spend. So it's certainly recognised that the better managed people are, the less they cost by the health insurance companies. Yeah, and they're not the only ones that do that. Yeah. And once again, some people like it, some people don't like it, patient-wise. Yeah.
For the services that you provided in the clinic that you worked in, how many doctors did you have working there?
12.
And how many nurses?
Very busy. So 2 nurses in the treatment room and 3 of us doing
Care
chronic
plans.
disease management. Yeah,
Yeah.
yeah. So, yeah, and visiting specialists. So, yeah. And we did a Dr. X system, so that meant if you rang up on the day and you want to be seen, you can come and sit and wait. So, yeah.
Could you just expand a bit more about the visiting specialists? So I understand what you mean, but I don't know if the other guys. So you'd have extra rooms that visiting specialists would come to.
Yes, so that's hot desking, which is known in a lot of other professions, not just general practice now, but yes, they would. So once a fortnight, once a month, so it might be cardiology. We had an oncologist, we don't need that now because we've got the specialist cancer treatment centre there now. We don't need as many specialists coming because we've got the specialists that came from Melbourne now consulting out of the Epworth, so that's been a real big bonus. And the Red Cross car will take people who don't have transport. But yes, they do, they cycle through. Yeah, paediatrician, we have a paediatrician comes from Geelong once a month and he has a room and sees people who don't want to travel down. Yeah.
So people with diabetes might have the renal physician,
That's
renal
more-
specialists come.
No,
No?
all of that now is more done with, online Skyping
Teleconferencing?
calls, teleconferencing, and that's going well.
Yeah.
Yeah.
So it's called telehealth,
Yeah, telehealth.
which is an electronic way of communicating, and a lot of really rural GPs will use it to telehealth with specialists.
Things like as follow-ups and things like that.
Yeah.
Yeah.
So they'll have
Yeah.
the patient in the room with them, and they'll telehealth on the
Yeah.
screen, and they'll have the consult, or the patient might just directly telehealth with the specialist.
And you have to book a time, and it can be for any reason. Sometimes it's because the GP wants the patient there with them while they talk to the specialist in real time. And it does require a bit of setting up because that GP can't be disturbed during that period of time. You have to make sure Skype's working. You have to have a closed space that no one's going to enter, and often you need interpreters. So that all has to be organised beforehand. But it's good. Yeah, it's been well received.
Just on what you're saying about interpreters, have you come across any cultural barriers or challenges in providing care?
I think the biggest, Colac's quite culturally diverse because we have a bit of industry there. We have a sawmilling place, timber place, and we're not allowed to say abattoir. What do they call it? Australian Lamb Company. And they seem to phone a friend to let them all know when jobs are going. So we have that population coming through from all different backgrounds. But our biggest challenge was when we, without any notification, I just overheard a conversation 2 weeks before it happened, had 50 refugees arrive in Colac overnight on a few buses. Oh God, I know. Thank goodness I had a fortnight because I overheard the conversation at a training day down here and said, sorry, what did you say? So that was really big because they would have refugee health checks, they would have all sorts of things. Well, we had no experience with that. We didn't know what we had to do. And then came all the tripping over to find out what they'd already had done when they arrived in the country and what needed to be caught up, which was so hard. But anyway, we got there, we persisted. And then sourcing things they could afford because some of the tests they needed, especially blood tests, because different countries have different diseases that they have to worry about. A lot of them had diseases with their livers and things that we didn't know about. We don't encounter it here. And the tests required had to be done in Geelong, or very, very expensive. So trying to find bulk billing places in Geelong to do that was tricky, and trying to get there first before the GP referred them to somewhere where they were suddenly told that's $300 per. So yeah, that was the biggest challenge, I think. Yeah. Yes. And you know, respecting culture. Culture is what that person says is culture. It's what's important to them, it's what they value, it's how they'd like you to treat them. And that varies from person to person, family to family. So I guess the best thing to do is ask, you know.
Did
is
you
there
need,
anything you need to be aware of?
with the refugees that came, did you need to do some research or learning
sure did.
yourself? Yeah, so what did you do to improve
there's-
your literacy around their culture?
I just got online and had a look at all the refugee health check requirement, which is, you know, your primary healthcare networks are now good. They put out all sorts of things. I got online to have a look and see what refugee referral centres were doing, what they were recommending. And you build it fairly quickly, but you've got to go out there and you've got to do it. And then it's getting everybody on board because you're just one little piece in the puzzle. Yeah. Nurses, if you like, because the nurses, I don't know about your clinic, but you're in the middle. We're in the middle. So you're the most accessible person in the practice and you're the most fluid quite often. So you're sort of the glue. You're going from here to here to here to here and trying to put everything together. So it really was that, trying to get everybody up to speed quite quickly.
Sounds like a lot of problem solving and like, you know, just coordinating and
Yeah, general practice is people love it or hate it. We've had girls come to work there and after 2 days said, you've got to be mad.
We've had a pretty large
No,
nurse
thank
turnover
you.
too.
And yet we've had other girls come and stay for years and love it. So it depends what you bring. I think you always need to work in acute care first and have a good understanding of acute care, because if you don't know how unwell somebody is. You know, you can see them there, but if you've seen them in acute, and certainly if you've seen them in intensive care, you know how unwell they can get. So you've got some idea about where they are. We'll use that as the health continuum. You've got some idea about where they are. Okay, they're not too good, but they're not in crisis. Or, yeah, I think we're in pretty serious trouble here. So I think always you should work acute first and come to general practice down the track, if you can. It's not mandatory, it's just if you can. Yeah. And I find that a bit, I might be wrong here, but I'm seeing it a fair bit now in paramedics. They're builders or brickies or whatever career they've had, and then they decide to go and train to be a paramedic. And they learn that acute module, but they've got no idea where anybody is on the continuum because they don't have a healthcare background. So that to me really added to the belief I had that you needed to know where somebody was. Yeah.
I think too, in general practice, like you've given good examples, like just eyeballing, just having to hear that there was going to be refugees coming in. You had to go into sort of, a management of a impending, difficult situation. So I think general practitioner and nurses in that setting have a very good adaptability to different, because of the variety, like it's such a diverse variety of patients that is seen, that, you have to be adaptable to different things and you have to be able to think on your feet.
Yes.
Because you're getting faced with different types of challenges, whereas you work in a surgical ward that, maybe it's orthopaedic, you're getting the similar sort of patients all the time. Whereas if you're getting that diversity, it's a lot more complex and not as easy as what you might think. Because although the acuity is lower, there's the complexity of people with many comorbidities, making those patients more complex. So, it's quite a skill, and I think you're right. I think you need to have experience before you go and work in that setting.
Yeah, you have to know where you're at, really. Or you'll miss things, and that's really a problem. Yeah.
So you were talking earlier about it'd be great to get patients to come in when they're well, and that's difficult. So what sort of things can you do? What sort of things would your practice do to actually do health promotion stuff? So instead of just taking appointments and doing clinics and doing procedures and stuff, do you actually go out? Do you get an opportunity to go out in the community to do promotion and prevention?
Not a whole lot, but certainly if the opportunity arises. So we've done some really big community immunisation sessions when it's been required. Q fever, when that was first funded by the government.
What's Q fever?
Oh, that's a bloodborne illness you get from cattle.
Yeah.
Yeah. So, well, maybe not from cattle now. They're starting to see it in city people that have never seen an animal. So that's being borne in somehow. But that was a huge immunisation program. Sometimes we'd be invited to speak at things, various health promotion things in the community, International Women's Day, things. The male doctors will often go to sporting clubs and RSLs and do talks there.
Oh, yeah.
That's all very valuable. Yeah.
So you just get community groups calling your practice to say, can you come and do some,
Will you talk at Probus?
Yeah. Will you talk, yes, Lions Club or, or Rotary or,
Will you talk at BFA?
Yeah, will you talk at BFA?
Did you do annual health assessments at home on patients?
Yes, yeah. So that was a nurse going into the home. Yeah. And if you read the small print, they don't have to necessarily go into the home if it's not feasible, but they really need to go into the home.
So
if
is
they
that like ACAT assessments?
No, that's if you're over 75, you automatically qualify. That was a hard one to sell because people thought you were coming out to assess them to put them into a nursing home. So it was a big scare around that. Where in actual fact, once you managed to get it through to them that it was the reverse, the government was spending money, and if the government spends money, it's to their advantage. It was to prevent them ending up in a nursing home. So you could pick up problems early and not wait until they were in stage kidney disease or, acute cardiac conditions and things, so they get picked up early. So after that, it became very well accepted. The only problem was they were all telling each other that they had to learn the things that were on the tray for the mental health assessment and to practice spelling world backwards. So it doesn't matter how old you are, there's cheats. They were practicing.
You count backwards by sevens.
You were just talking about how important it is to be able to go into the house. These guys did an assessment back in Cluster 2 around going into a patient's home and the things that they observed about the patient and the things that they told them about the risks that the patient posed. So,
You have to. If you're not there, you can't see that they've just put the electric kettle on the gas stove. And that would happen. Yeah, or I'll make you a cup of tea, I'll put it in the microwave, and they walked over and put it in the freezer. You know, you just not coping at all. You know, dementias that are creeping in, and people are trying to pretend it's not happening. So unless you're there, yeah, you don't see that. But it's pretty well accepted. Yeah.
It's like primary health also reducing stigma.
In what way do you think?
Like as you said before about them being so afraid of going into the healthcare home that they've made a stigma attached to being assessed. I don't know how to explain it.
I think it's the fear that they would be then pushed to go into a nursing home, and they wanted to maintain independence. Yeah, so it was to make sure that they felt comfortable that that was the opposite. They weren't going to be encouraged to go into care. They were going to be assisted to remain independent.
I reckon, Kate, are you saying that the nurse spends a lot of time relationship building, trust around actually accessing primary health care? Is that what you mean? Or
Or Aboriginal and Torres Strait Islanders, you're thinking more about that?
No, I'm thinking like people who don't know the healthcare system, like elderly or people who haven't had much education towards it, could have like an opinion or like bias towards it, and then they'd be afraid of it.
Yeah.
So then they'd build a stigma up to it, and then
Yeah, that can be, and we all have biases. We think we don't, but we do. We all have biases. They're unconscious, but they're there. So yeah, they sure do. Yeah, for all
and
sorts
then
of reasons.
is it like primary health? Is primary health also to reduce them being scared and to
Afraid.
educate them?
You hope so. And the other thing that's really important, and the smaller the community, the more important, is privacy. That's so important to people. And it's a minefield in a small town. You know, somebody got online and said, oh, that idiot in the red jumper was here. And somebody knew who that was because they'd seen them come out, you know, and that just absolutely hit the wall. So people have to have confidence in lots and lots of areas, and privacy is number one, I think.
it would be even more so in primary healthcare in a small community, because we talk about it at Barwon Health, you know, there's always people that come in that you know, but a big hospital, it's a bit more absorbent.
Yeah.
But in primary health, you said there's only 3 of you, 4 of, you know, however many of you in that clinic. And especially if you live in the community as well, it's there's some conflict of interest, and we've talked about professional boundaries and the nurse's code of conduct, and the importance of all those things would be even more heightened in
Very much.
your primary healthcare situation.
And scope of practice. You know, if you work in any of those areas, you've got to be so aware of what your scope of practice is, what you're trained to do, what you can talk backwards and forwards and be really confident doing, because you're responsible. So you have to pay for your own insurance, and you have to check off against the clinic's insurance every procedure you do, because if they're not covered for it, you're not covered for it. And the biggest area of litigation against nurses, it's just out there all on its own, is ear syringing. So it's blitz the field with people trying to sue nurses for what they perceive as a property.
Obsolete.
Yeah.
Yeah.
I'm going to lead into our last question because we need to tie up, but I was just going to ask you, would you be able to tell us a little bit about what APNA is? And
yes,
so does that lead nicely into, you were talking about indemnity insurance, and so what's APNA?
Yes, Australian Practice Nurses Association, and you don't have to have your insurance through them. You can have your insurance through Australian Nursing and Midwives Federation. They'll provide that too with your registration. That's your union body who look after, hopefully, the profession and keep trying to get, well, practice nursing is the only branch of nursing that doesn't have a mandated pay rate. So basically GPs decide what they'll pay nurses, can you believe? And it's been to the highest level twice and they got nowhere with it. So
Might be the
if you haven't
attrition
got
rate
your
you're talking
A&M,
about.
if they're fighting, you are never going to get anything. Like, they work so hard to fight for that. So you can have insurance through that. Australian Practice Nurses Association is a great outfit. They provide a lot of support. You pay, of course. They provide a lot of support. They provide a lot of education. they provide a publication, and it's always really relevant, and it's always very much tied to what you do. Yeah, I should have brought one down for you. It's called Primary Times, and it will have a lot of information about your profession, and it'll have a lot of information about health problems that you're going to face. Yeah.
How an old nurse gets less money than I do as a receptionist.
Yeah, and that's because they can. And being in management, it's a wonder I lasted there as long as I did. Just say, how does it work? Like, you know, you guys, can you decide what you're going to pay the plumber and the electrician when he comes to your house and does your work? And they just kept saying, don't play ridiculous. But it's still that mindset of, we don't have to. So.
Yeah. So does everyone understand that? So the EBA doesn't apply in general practice because it's ANMF has negotiated that purely for public health service.
Yeah. Well, they tried to negotiate it, and the first time they went there, the representative for the AMA, which is the medical representative, wouldn't participate. They just sat in the front row and laughed. And then the second time they brought them back, sad to say, nurses aren't trained particularly well in business, and often you'll be working for organisations that you don't know the name of. So you might say, if you were asked to fill in some paperwork, which is what happened, you know, yes, I'm an enrolled nurse or a registered one-div nurse, I work at Eastbourne Clinic, and these are my hours, and this is my rate of pay. Off it all went with the lawyers for the AMA, full well knowing it was all going to just come up before the court and get thrown out, because you mightn't work for Eastbourne Clinic, you might work for amphibians.com. You know, the companies just have names. So nobody knew who was paying them because the companies have names. So it's a good idea to have a look at that if you can. Find out who's paying you if you ever work in general practice or a private primary care, because they're the people who are making the rules around having you there. And you have to know what their insurance policies are, as I say, because otherwise you're out.
It is a big complaint. A lot of nurses in primary care complain about the wages.
Yeah. And it's very hard in a town like Colac, because the thing that divides us from the hospital is a not very wide road. And to get girls who are well trained to walk across that road and give up penalty and give up a much higher long service leave entitlement, you know, they say, no, thank you. You know, so
It's hard to get nurses.
very hard to get nurses. And then you have to work very, very hard.
Oh, it's really hard.
It's
in there.
the phone's ringing, the doctor's barking at you, the patient's there waiting for you, and it just goes all day. Yeah. And you never finish on time. And you also have to be prepared to do a lot of cleaning sort of stuff that
Changing
now
sheets
is no
of
longer required in every other area of nursing. But if you don't, it won't be done. It won't be up to standard.
Haven't got the bed cleaners like we do, or the techs.
No,
We've actually
actually.
taken a fair bit of
We've got
the,
they're downstairs. They've got to hear it.
so we can give out results as receptionists now. We're qualified to do that. We can do some triaging.
Yeah, we triage.
We book all the care plans in. So we've taken some of that load away from the nurses because they're so inundated with immunisations. We have travel immunisations and things like that, and they have to think on their feet all the time.
Yeah, and it's good. It's so good if you get on with your reception staff. Sometimes you can have some little jealousy things happening, which is just in any workplace. But if you get along really well, that's tremendous. Yeah, and immunisations are a big one to make sure people are up to date if you can. Yeah.
I'm afraid we're going to have to wind it up there because we've got another guest speaker coming. So if everyone would like to thank Sue for coming in today and giving up her time.